Good evening, everybody. My name is Jill Dannenfelser, and I'm here today to teach you about the pediatric asthma pathway. I'm very glad that this group of emergency room nurses was able to gather tonight for this in-service before starting your shift. We're going to start with this brief case study to get your minds thinking. So a 7-year-old female presents to your emergency department with audible expiratory wheezes. The patient was sent into the emergency room from the nurse in her new school. She has audible wheezing, nasal flaring, and slight retractions. What is your initial plan and what questions do you want to know? Yes, go ahead.
What is her history and what is her oxygen saturation?
Excellent questions and very valid points. Those are probably our two top priorities. I'd like to get a few more responses. Very good, excellent. And now let's move on and learn about asthma, and we'll come back to this in a discussion at the end. So the objectives today, or the items that we really want to cover, are we want to list the common causes of asthma exacerbation, the signs and symptoms of an asthma exacerbation, and then we want to take the time to go through the asthma pathway of treatment in the pediatric emergency room. So first, what are some of the common causes of asthma? Often they're divided into two categories: extrinsic or environmental factors, and intrinsic, or things we can't control that are from our inside our body. Extrinsic factors would be considered pollen, cat hair, cologne, chemicals that you smell, different things in the environment that could trigger an asthma attack. Often changes in weather or changes in the environment might trigger that asthma attack. Also, one of the top things that triggers asthma is smoking. Intrinsically, or inside the body, asthma can be triggered by viruses, infections, either bacterial or viral, physical or emotional stress, and then you can also have exercise-induced bronchospasm. So what are the signs and symptoms? What are you looking for when they present to your emergency room? The patient will be breathing faster or tachypnic. They might be hypoxic or lower saturations. They might be coughing, and the coughing is a response to one of those triggers we just discussed. And they might complain of chest tightness. Classically, asthma patients are going to be wheezing, so you need to take that stethoscope and listen to their lungs. We're going to take a moment to watch a video clip, a video presentation on asthma, and listen to what those lung sounds will sound like. The video clip is a little bit long, so right now we're only going to watch the first few seconds of it for this presentation only. So perfect. You're going to listen to the entire video clip so that you can understand asthma in the future. But for now, we just heard what wheezing sounded like. That patient was having expiratory wheezing. So wheezing can be inspiratory when they breathe in or expiratory when they breathe out, or both. In that case, we were hearing some expiratory breathing. So I hope you enjoyed that video clip and it helped you understand what you're listening for with your stethoscope. Once we determine the patient definitely is having an asthma exacerbation, we need to go through the asthma pathway of treatment. The very first step is to immediately deliver oxygen to prevent hypoxemia. Patients' saturation goals should be 92% and above. You want to start with the least invasive means of delivering oxygen, either nasal cannula or simple face mask, and then progress through the different levels of assisted devices to meet the patient's needs. So after a nasal cannula, you might have to move to the oxygen mask, and then you might have to move to non-invasive positive pressure, and finally endotracheal intubation. Endotracheal intubation should be avoided as much as possible in the asthmatic patient. Unfortunately, that asthmatic patient's lungs are already inflamed and in bronchospasm. So by putting a plastic tube into their trachea, you're going to cause more issues. In the case of an asthmatic that requires endotracheal intubation, the most experienced provider in the room should be the one completing the intubation. The second step in the asthma pathway is to administer bronchodilators. We want to open up those alveoli and the portions of the lungs that are in bronchospasm. The first line of defense for asthma is albuterol. Albuterol should be administered via a nebulizer in the emergency room. Frequently, they will also add another medication called Atrovent to the inhaler. And when the Atrovent and the albuterol are given together, it is called a duoneb. The typical pathway will give the patient 3 back-to-back duonebs, trying to relieve that bronchospasm before moving on to a more invasive procedure. The third step of the asthma pathway is to deliver systemic glucocorticoids, or a steroid. Steroids or glucocorticoids will take about 2 to 4 hours for you to really see any differences in the patient. It will not be an immediate difference where you'll notice decreased inflammation and the patient breathing better. The glucocorticoid that the physician picks is kind of variable depending on the institution that you're in, but typically they go with prednisone, salumedrol, or dexamethasone. It'll also depend if you have IV access or not as to which medication you are able to give. Again, that's going to be provider dependent and to always follow your orders. The third, and as we're progressing down the asthma pathway and you notice the patient is significantly declining, we're going to be giving a magnesium sulfate intravenously. So at this point it's required that you have IV access to be able to give the magnesium sulfate. One of the key things with magnesium sulfate is it causes smooth muscle relaxation. So every smooth muscle, not only the lungs, is going to relax. This can cause hypotension in the pediatric patient. It's very important that you monitor their blood pressure during the administration of magnesium sulfate intravenously. The fifth and final step that we're going to discuss here in the asthma treatment pathway is the administration of either subcutaneous epinephrine or intramuscular epinephrine, or the other option is to administer terbutaline. Both of these are intravenous beta agonists. One of the important key tidbits to remember with terbutaline is it can cause cardiac ischemia. It doesn't always happen, but it's something we have to monitor for. Before starting terbutaline, it's important to get a 12-lead EKG on the patient and to draw serial troponin levels during the first 24 hours of administration. Terbutaline will be started with a bolus, followed up by an IV infusion of the medication. So we're going to have a little bit of a group discussion about our case study that I presented in the beginning. Since I've covered a lot of information, let me remind you of the patient that was presented in the case study. Remember, you had a 7-year-old female who's presented to your emergency department with audible wheezing. Mom did mention that the school nurse at her new school had sent you to the emergency department for treatment. When she arrives, you notice that she's having slight retractions, continuing to have some nasal flaring, and audible wheezing. When you go to listen to her, you also obviously will hear the wheezing. What are some of the initial things from this presentation that you need to be concerned for? Does anyone have any ideas? Yes, go ahead.
What's triggering her reaction?
What are some of the triggers that we discussed that you might just see right in this case study?
Could be an environmental trigger with her new school.
Excellent. That is the absolute appropriate answer. So she started a new school and is now being exposed to a whole new list of allergens. There might be mold in the school. There might be significant dust or pollen. You don't know what those allergens are, so that is an excellent idea. We're going to continue this case study by talking through what your treatment plans are. What is your first treatment for her?
Put her on oxygen.
So that is an excellent response. However, first we want to check her oxygen levels and make sure she is greater than 92%. Now we're going to work through the entire pathway as a group and talk about the different options. Excellent job. So, in summary today, remember asthma is triggered by environmental and infectious agents within the body. Those external and internal and extrinsic and intrinsic triggers. Asthma symptoms are the wheezing, dyspnea or tachypnea, so shortness of breath and breathing faster, hypoxia, which we said was under 92%, and coughing. And coughing, again, is usually triggered by a specific exposure. The emergency room should follow the asthma pathway to treat the asthma exacerbation in a pediatric patient. So if you have any additional questions, I want to go ahead and leave my email address up here. Obviously, I would like to ask, does anyone have questions? Okay, if you come up with questions later on, please go ahead and send me an email. I'm happy to answer them. And as required, I want to go ahead and share my references with you that I would be very happy to send to you if you want to do some further research. Again, I'm very pleased that you were able to take some time before your shift started in the emergency room tonight to gather as nurses and listen to this presentation. Thank you.